Good morning and Happy New Year. It is a privilege and a pleasure to introduce Dr. Bradley Welling to this audience. Dr. Welling is the Walter Augustus LeConte Professor and Chairman, Department of Otology and Laryngology, the Harvard Medical School, and Chief of Otolaryngology Head and Neck Surgery at the Massachusetts Eye and Ear Infirmary, the Massachusetts General Hospital in Cambridge. His curriculum vitae is a manual for success that could be applied to our discipline and indeed to any field. Talent, training, perseverance, and hard work. He exemplifies to the highest degree those attributes which comprise the perfect academic physician and surgeon: excellence in clinical care, research, and education. His CV is too fruitful to summarize in this brief time. It reads like a who's who of otology, neurotology, and skull-base surgery. His undergraduate education and MD were completed at the University of Utah in Salt Lake City. Dr. Welling's internship and residency in ENT at the University of Iowa Hospitals and Clinics in Iowa City. His fellowship in otology, neurotology, and skull-base surgery at the Ear Foundation, Vanderbilt University, Nashville. Along with clinical medicine and surgery, Dr. Welling holds a PhD in pathology from the Ohio State University, where he began his academic surgical career, advancing to vice chairman, then chairman, and full professor. He has been professor and chairman at the Mass Eye and Ear, Harvard, since 2014. He has over 100 peer-reviewed journal publications, numerous book chapters, and hundreds of invited oral presentations. His funded research projects include numerous local, regional, and NIH awards. He is a member of all senior otologic and neurotologic societies and has served our societies in many leadership positions. He is the recipient of numerous awards in our specialty. His topic today is geared to our residents and attendings, avoiding complications in otologic surgery. Please join me in welcoming Dr. Brad Welling as our first guest lecturer in this new year.
Thank you, Dr. Lindstrom. That was the nicest introduction I've ever had. As a matter of fact, if you want to take a little more time, I thought that was, I'm going to record that for my mother. So Happy New Year, everybody. Thank you for inviting me. It's a great pleasure to be here, and I hope that for those of you who are non-otologists in the group that you won't mind this. For those of you who are residents or budding otologists, hopefully it'll have some interest. But I wanted to talk about vestibular schwannomas, and Eric said, no, people aren't interested in that. He said, talk about something more interesting. So I hope this will fit the bill, but thank you for the invitation. I'd like to tell you my financial disclosures. I have none that are relevant. The J. Morita Company did sponsor a trip to Japan. I got to see the Tsuruga Joe while I was there, and I gave a temple bone course a while ago where Stryker paid my way, so I thought I'd mention those just for completeness. Now, usually when we talk about level of evidence, we want to talk about meta-analysis of randomized controlled trials, and when I'm talking about avoiding complications, I'm right here at the top of the scale. This is mostly personal experience, so I hope you'll forgive me for reflecting on the last 30 years of my career and pointing out some things. But let me start with this story. In 1986, I was a third-year resident at the University of Iowa. I attended the annual COSM meeting down at the Breakers Hotel in Palm Springs, and there was a case presented there that I thought was interesting. You know, we don't put a lot of weight in case reports, but it was reported that during a translabyrinthine excision of acoustic tumor, that during the harvest of the abdominal fat graft, the tissue didn't appear normal, so they sent it off for a frozen biopsy. It came back normal sigmoid colon. Now, you might think that's not a highly significant report, but to me it was. And every time, Dr. Tweel's in the audience, one of your new faculty here, every time we have folks harvesting abdominal fat during translab, I remind them, you know, stay on the outside of the fascia, just get the superficial fat there. We don't want any normal sigmoid colon biopsies. And so that one case report back many years ago reminded me that we can learn from others' mistakes. And in fact, I'm sure you've all seen this quote. It's attributed to various authors, but Mark Twain may have been one who said, good judgment comes from experience, and experience comes from bad judgment. Well, I will show you an actual example of this at the end of the lecture. I'm going to give 10 tips, I think, that I've learned over the years in terms of avoiding complications. And some of these might actually pertain to other areas of otologic or other otolaryngologic surgery. But the first is to learn from other people's mistakes. I think I did learn from their mistake. I've been very careful, and thankfully in the last 30 years, I've not biopsied the sigmoid colon inadvertently. But we'll go through and walk through, and I'll just tell you a couple of tips along this line. And Lisa's going to keep an eye on the time for me, right? Okay. So the tip number one, learn from others' mistakes so you don't repeat them. Secondly, preparation. Now, these are things we heard in medical school. I remember as a medical student, they said 50% of what we teach you will be wrong. We just don't know which 50%. The one thing that they taught me that I do remember, and I think it was true, and I still believe it, is that a careful history and physical examination are important. So in otologic surgery, of course, we always want to have an audiogram available and imaging and consents and so forth. And there's, as Dr. Corey, your new director of quality, will assure you that these things that have been put into place now are for our protection and for the patient's protection in terms of the consent and the preoperative marking and so forth. This is something that we've done for a long time, but certainly important to make sure we have correct side. We review the consents in the preoperative area, as well as, oops, sorry, let's see if I can get this right. I have a, yeah, okay. So, and then once we get into the operating room, of course, in my lifetime, the timeout has been instituted where before anything is done to the patient, the timeout is done to certify the correct patient side and marking the skin site and so forth. I always put a big purple W on there, and it's for welling. I tell them I've tattooed it in there, but it's not true. It comes off. We want to make sure that the audiogram is in the room and that the imaging is up and available. And we go through and remind the staff and all of the folks in the room that if there's anything that seems to be amiss, that they speak up and let us know so that we can avoid potential complications. So let me talk to you about a case of wrong-sided surgery. If we do these things and do all of them, we won't have this problem. And the last little caveat for the otologist, I'd say that any of the things you've done, I always reconfirm intraoperatively before removing the labyrinth, just to be certain one last time. Now, this is a 27-year-old man who fell about 3.5 meters off of a ladder, sustaining head trauma with loss of consciousness. He fractured his left temporal bone, sustaining a profound left facial paralysis and sensorineural hearing loss, kind of a transverse fracture through the cochlea. So we planned a left translabyrinthine facial nerve decompression. An error occurred in the scheduling, and the patient was rolled into the operating room where he confirmed that he was having a right ear operation. Possibly he was still confused from the head trauma. The resident began the case and did a mastoidectomy on the right side. I sat down, I removed the incus, and before I drilled out his labyrinth, I checked the information and discovered the mistake. We replaced the incus, put gel foam around it, closed the ear. I went out and discussed the situation with the patient's family. I did not wake him up. I wasn't sure his mental status was good enough to discuss the situation. We did turn the patient around and do the other ear, and fortunately his hearing returned to normal in the right ear. His facial nerve function also returned well. Surprisingly, there was no lawsuit filed. The secretary resigned without being forced to do that, but she felt very terribly about what had happened, and I'm not blaming her. I think that there are a number of steps that I instituted since then that helped prevent this. But if all of the steps are followed every time, this will be avoided. And I think Dr. Corey will never have to talk to you about these steps. And I'm sure you all do these things now, but in those days, we didn't. I always schedule the cases in writing with my signature. If this case is not scheduled with my signature, it doesn't go on the operating schedule. And I always like to be there. I always am there for the timeout so that I can make certain that things are as they should be. And the images, the audiogram are checked preoperatively and are in the room. Before the incision, timeout, and the audiogram are there. Every member of the team is expected to stop what they're doing and listen. If somebody's talking, we wait, we stop. We really take it seriously now. So the last tip on this one is just stop before you do a labyrinthectomy. One more time, check everything. It saved us in this particular case of deafening his only hearing ear. Exposure. Well, poor exposure can make even the most simple procedure, the most straightforward procedure, difficult. So when you're doing otologic surgery, you don't have a lot of room. You can't tolerate much ooze or bleeding. One of the keys, one of the little tips is to use the largest speculum possible if it's a transcanal procedure. This helps to maintain hemostasis, an internal tourniquet of sorts. Also, as the canal expands, you can enlarge the size of the speculum so that it it continues to maintain hemostasis. If you're working through a postauricular approach, you don't want to occlude the view by an inadequate skin incision. So you want to hinge the pinna at the level of the anterior external canal wall. And this is what I mean. A lot of times the incision, the postauricular incision, will come from behind the external canal, whereas if the incision is carried a little further forward, then the pinna can be reflected in a way that the pinna itself doesn't get in the light and cause problems with visualization. Another small tip is just not to make the postauricular flap too large. If this is only a centimeter to, or half centimeter to a centimeter, it doesn't flop back in the way, and the retractors will keep it out of the field of view. And this shows the extension of the incision that will allow better postauricular visualization. Hemostasis is crucial. We do this by several injections. One with a concentrated lidocaine mixture, 1% lidocaine with 1 to 10,000 epinephrine in the canal. We use a slightly more dilute solution for children. The degree of hemostasis that's obtained with this isn't necessarily better than with a more dilute solution, but it lasts longer. And so if the case goes more than an hour, hour and a half, you don't start to get the oozing you do if you use a less concentrated epinephrine solution. The postauricular crease, the concha, and the tragus, we use standard 1% lidocaine with 1 to 100,000 epinephrine. This is a grainy intraoperative view of a middle ear that has a prosthesis and a lot of blood in it. You just can't operate through that. So if you get into that situation, stop, use topical adrenaline on gel foam that's been well squeezed, and get that under control. If there's any ooze or rundown from the soft tissues, make sure that that's taken care of. Another thing to be careful about are vascular anomalies within the middle ear itself. Here, as you look through the tympanic membrane, you see a purplish blush in the posterior inferior quadrant of the middle ear. And in fact, there are some folks who have a dehiscent jugular bulb in the middle ear. So as you elevate a flap down the external auditory canal, you can get into that vascular structure very easily. And recognizing it ahead of time on a careful physical examination is very useful. When you do come into a high jugular bulb, either in the middle ear or in the mastoid, because it's a low pressure system, it can be controlled with gel foam overlying the jugular bulb and a neuropatty on top of it. In a little bit of time, it will stop. This is another view through the ear canal of a pinkish blush in the anterior mesotympanum. And here the tympanomeatal flap has been elevated. You can see something that's pulsatile. You can actually see it through the drum as well. And this is a dehiscent carotid artery in the middle ear. There's a very famous video in the house ear collection of somebody biopsying a pulsatile mass like this. And as you recall, with the biopsy, there's a big blush of blood and the lens becomes red. You don't see anything after that. Well, you don't want to biopsy that. You don't really even want to stick a needle in it. What you want to do, of course, is to see it on the CT preoperatively and recognize it for what it is, which is something you really don't want to biopsy or address surgically. So, 52-year-old man was undergoing a left tympanomastoidectomy for chronic mastoiditis. He had a history of polyposis of his sinuses and aspirin sensitivity. He had very dense polyposis in the middle ear as well. During resection of the mucosa of the middle ear up around the eustachian tube, a bright red gush of arterial blood was seen. We alerted the anesthesiologist and switched to a large bore suction, number 7 suction, to be able to maintain some degree of visualization. We were able to pack the orifice of the eustachian tube with Surgicel, and that controlled the bleeding. But it was obviously arterial and most likely internal carotid, so we did an intraoperative arteriogram, which showed that we had packed off the bleeding but had not stopped the flow completely through the carotid, and there was collateral flow through the circle of Willis. So we went ahead and completed the mastoidectomy. A week later, the patient came back to the emergency department with epistaxis. With nasal packing, it was controlled, interestingly. A repeat arteriogram at that time showed a petrous carotid pseudoaneurysm. So he was returned to the operating room for distal balloon occlusion of the petrous carotid and proximal ligation. A rather harrowing situation. This happened when I was a fellow, actually. I got to fly from Nashville to Cincinnati, where they were doing intraoperative occlusions of that, or intravascular occlusions. So the tip, if a vascular injury occurs, particularly of an arterial structure, use a large suction, pack the eustachian tube if necessary. If that doesn't control the bleeding, pack the middle ear with Surgicel and pack the ear canal. Intraoperative arteriogram is very useful then to look at the circulation and to assess for occlusion of the carotid and for cross circulation. If it's a jugular bulb or a venous structure, overlying gel foam with a cotton pledget will be sufficient. Doesn't need to be packed off. Dissection tips. What are some of the things that can keep you out of trouble with various dissection tips? Well, one of the things that I like and I wanted to share with you is just the use of loose connective tissue which overlies the temporalis fascia. When you're cutting through the postauricular muscles, if you stop, as soon as you get through the postauricular muscles, there's a layer of fascia there that is really loose connective tissue that can be used and harvested and used as a graft for tympanic membrane reconstruction. This is thick enough to be very useful, and it saves the temporalis fascia in case you're unfortunate and have to go back sometime in the future. The fascia layer this is the demonstration how the underlying temporalis fascia is thick. This appears thinner, but this can be elevated by injecting with just some saline or lidocaine, injecting a bleb, making a small incision underneath it, elevating this lateral layer and then pressing it out and drying it, leaving the temporalis fascia underneath. It makes a very nice graft, and when it heals you can see through it. It's a little less thick than the temporalis fascia, but then it gives you temporalis fascia in case you've got a recurrent perforation at some point. Not that any of you ever have that happen, of course, but it makes a nice large graft as depicted here. So suction irrigation also. Adjusting the flow of irrigation to be continuous is very useful, except when so you want to be able to turn the irrigation on and off with the thumb. If you intermittently irrigate and suck with the non-dominant hand, it allows for continuous drilling motion. This shortens the case by hours. Maybe you'll notice when you're in the temporal bone lab early on in your career, you'll find yourself drilling and then sucking, going back and forth. Dr. Tree will tell you we would emphasize the continuous motion of the drill with intermittent suction irrigation to remove the bone dust, and it will make a 4-hour case a 2-hour case. So it's really very useful, and it allows very good visualization. And this shows a linea temporalis, and we want to start high enough above the external auditory canal when we start this so that we can identify dura underneath the temporal line. We remove adequate soft tissues. If the temporalis muscle is not pulled up high enough, then we don't start the dissection high enough, and people can get lost in a mastoid that's full of chronic disease. Self-retraining retractors keep the muscle out of the field is useful, reduces the bleeding. And then we really want to saucerize the bowl. I find that one of the most common problems when ear surgeons are getting started is that they make very sharp walls into the mastoid cavity, and it makes it more difficult to get access. The instruments can't come in from an angle, they have to come straight in. It reduces the field of visualization, and you don't see the structures that help you to localize where you are. So when you're drilling a mastoid, if you'll remove the outer cortex so that it's not hanging over and doesn't give you straight walls, the saucerization, the removal of the outer lip of the external auditory canal, gives a much wider view. So when you're looking for facial nerve, looking for the incus, it helps to avoid problems that you'll otherwise encounter with poor visualization. Probably the most important point of this lecture, actually, if you're going to be an otologic surgeon, is to become comfortable at identifying and following the facial nerve. The good otologic surgeon knows and follows the facial nerve, keeps it close to them. Some people say, oh, I don't ever get close to the facial nerve. I want to stay as far away from it as I can. Then it's dangerous. If you don't know where it is, then it likely could be in the field and you wouldn't recognize it. So the tips for finding and following the facial nerve are to first identify the incus and the antrum. Irrigation will reflect the water around the corner so you can see the incus before you come up to it with a drill. The posterior inguinal ligament is white and it's shown in this area. The surgical bridge is here. The chorda tympani and the facial nerve then will be directly below that short process of the incus. So in dissecting safely, start from the known and go to the unknown. You know where the mastoid cortex is. You can see it underneath the muscle. Expose it well, and then remove the cortex down to where you can see the middle cranial fossa dura, medial to the cortical bone. If you're too low, you'll leave air cells near the tegmen, and it'll confuse you. It's easy to lose your way. You don't want to confuse your entrance into the additus, so that you would ding the incus with a diamond burr, which causes sensorineural hearing loss. The facial nerve can be damaged or lost if your way is lost, and this can certainly happen in a diseased mastoid that's full of granulation. So finding and following known structures is really important. So the landmarks, first of all, the middle fossa dura. By removing enough cortex, you can follow it down into the antrum. By finding the additus, then you can safely find and follow the facial nerve. And coming back posteriorly and finding the sigmoid sinus really gives very nice landmarks and gives a wide open mastoid for visualization of the other critical structures as you get down to the semicircular canals. Okay, facial nerve dissection. This is just what I was showing. We use a 4-diamond burr in the facial recess, just inferior to that short process of the incus, and sometimes folks will be inclined to go to a smaller burr before they completely see the facial nerve. It's not a good idea. It's safer to use a 4-diamond burr, a 4-fine diamond, to identify that facial nerve. Follow it clear down to where the chorda tympani takes off, follow that up, and then if you're going through the facial recess to access the middle ear for a cochlear implant, a 2-diamond burr then is reasonable. But identifying that facial nerve clearly, as shown in this image with the chorda tympani, is really important. And then you've got nice access here to the middle ear. So what about facial nerve monitoring? How does that help us avoid complications? Well, I think it is useful, and I think that's been shown and proven over the years. It certainly alerts us for trauma, tension, heat, the facial nerve. There are positive artifacts, false positive artifacts that come out of it, particularly when metal is rubbing against metal. Those of you who use the nerve monitor know that's a very common false positive. False positives don't worry too much. It's the false negatives that are concerning. When there's no signal from the monitor when the facial nerve is actually stimulated is more of a problem. And the most common source of that is if the probe tip becomes loose, or other things can happen. Usually the monitor will alert you if one of the wires becomes loose. But the point here is that you really don't want to become dependent upon the facial nerve monitor. In order to be a safe otologic surgeon and avoid complications in the facial nerve, you want to be able to rely on good anatomical landmarks to find and follow the facial nerve. And there are times when the nerve monitor will malfunction. I've had that happen recently, actually. So this is a patient who was referred following a stapedectomy for a left House-Brackman grade 5/6 facial paralysis. Upon re-exploring the middle ear, a prosthesis was found impaling the dehiscent facial nerve. This is an artist's rendition of the way that the nerve appeared. The fallopian canal, interestingly, appeared normal. However, there was a band of soft tissue that came right over the oval window, which was the facial nerve. When you see this, the crura of the stapes will sit on the soft tissue and not touch the footplate of the stapes, and so it'll actually appear mobile. And a broad band of tissue going across the oval window can actually be a flattened facial nerve. So be cautious if you see that and stimulate so that you don't wind up with this situation. And you'd think this is quite uncommon. It's true, it's uncommon, but we reported several cases of this. And so watch out, don't do that. When you do have a facial nerve injury, there are many schemes, and we won't go through all of those, but for an immediate paralysis, the ENOG is out greater than 95% between 3 days and 14 days. Immediate exploration and decompression may be useful. If there's a bony spicular or other problem in the nerve, it may be helpful. There's some debate in the literature about whether or not decompression opening the sheath is useful. I would say that one of the things you see is if there's greater than 50% of the nerve gone, that you take it out and graft it. I would disagree with that. I'd say If you've still got fibers intact, use those. Only graft the portion of the nerve that's been damaged so that you can have less synkinesis when things heal. And these are the various return of function that you might anticipate with cable graft. So tip number 6 is don't remove soft tissue over the oval window without being certain it's not a dehiscent facial nerve. On cholesteatoma, a few things. I think a high-resolution CT is useful when patients have symptoms, especially of a fistula or facial nerve irritation. The new diffusion-weighted imaging, not so new now really, was very helpful to detect recurrent cholesteatoma. And mental ear endoscopy is useful for looking around corners, looking into the sinus, tympani, retrofacial cells to see if there's any residual cholesteatoma. This is a nice image from Dr. Yanagihara in Japan, who showed this high-resolution scan that shows not only dehiscence in the vestibule, but also in the facial nerve, the fallopian canal, and the 3D reconstruction looks like it's open. And in fact, this cholesteatoma had eroded into both the horizontal canal and the fallopian canal. This is a patient who had an interesting lytic lesion medial to the labyrinth here, and on an MR without gadolinium, it appears this way. The T2 weighted image showed some enhancement, but on diffusion weighted image it was quite bright, and this turned out in fact to be a cholesteatoma, which was medial to the labyrinth. Endoscopy is very useful for looking into the sinus tympani, looking around corners, places where cholesteatomas used to be able to hide. I don't use endoscopy for primary dissection, but I do like it for checking places I can't see well, and I think it's a nice adjunct. So another little story here. In 1989, I was first year in practice. Chief resident was assisting me with a case where there was cholesteatoma filling the oval window niche. While dissecting around the stapes with a right angle hook, I saw it about to happen, but I didn't say anything fast enough, and they pulled up on the facial nerve, which was dehiscent, and the facial nerve was impaired. So I did not warn the resident in time to avoid this complication. So the tip for those of you who are training residents is to think a step ahead and warn them in advance of what might be about to happen. And so now I would have said to them, now you realize the facial nerve may be dehiscent with this cholesteatoma there. Be careful if you're dissecting that you don't pull up superior to the oval window. I think that it's a skill that can be learned. It makes us more competent as educators when we're teaching surgical skills. And there are times when we should do the key and critical portion of the procedure as faculty to demonstrate to the resident or fellow essential techniques if their skill level is not yet sufficient. This demands close attention by the trainee, and I would say that there are times when there's chatter in the room or things going on where I think that it would be much more useful for the trainees to pay close attention to every detail. And it's likewise, the mentor has to pay close attention when the trainee is working. So chronic mastoiditis, I'm going to jump ahead here. I think my time is running short, but remember the dehiscent facial nerve. When there's a lot of granulation tissue in the middle ear, clean up most of it except for the part right around the oval window. Pack the middle ear with gel foam that has 1 to 1,000 epinephrine in it. Address the mastoid disease, then come back and do the last little delicate dissection at the end of the case. All right. So one of the nice things we have that can help us avoid complications is practice. Thankfully, we have temporal bone facilities, and in fact, we have virtual temporal bone environments these days where we can practice. This is courtesy of Dr. Greg Wyatt, one of my colleagues when I was at Ohio State, who has worked on this virtual temporal bone model that not only has realistic anatomy, but also bleeds, which is kind of nice. And you can irrigate. So I just wanted to show you that because I think it's a nice thing to be able to get into the lab and practice these things. So ways to avoid bloody fields are to do a sequential dissection where the majority of the granulation tissue is removed from the middle ear, away from critical structures. Polishing the bone in the mastoid with a diamond burr is useful to help keep things nice and dry. And doing an adequate meatoplasty is really important. I usually don't let the residents do this. The reason is because I'm the one who cleans out the mastoid bowl after they're long gone. So the way that I do a meatovoplasty is to remove the conchal cartilage in this area from behind the ear, and then make an incision, one up through the incisura, the other coming under the antitragus in this direction, and then I put a suture through that flap of skin posterior-superiorly to drape the skin up this way, and it leaves a very adequate meatovoplasty. You might think that looks too big, but actually they close a little bit, and generally speaking, the view is quite adequate for cleaning the mastoid bowl in a canal wall down situation. It makes one's life easier in the care of the bowl, and a lot of them will become self-draining also. I'm going to jump over that. I'll jump over this. Just say a couple of words about stapedectomy here. How do you avoid complications in stapedectomy? Well, first thing, of course, is to get adequate exposure. A nice tympanomeatal flap that's long enough to cover any area of the external canal that you remove, and making sure that these incisions are carried far enough forward to get a 12 o'clock to 6 o'clock elevation of the flap, so that when the flap is pushed forward, you have a good view of the middle ear. Keeping the dissecting instrument right against the bone of the ear canal is very important. There's a tendency to want to push the flap away as you get close to the drum. This can cause a perforation or tearing, especially right as you come around the bony annulus to elevate the fibrous annulus. If you push forward, it can cause a tear in the membrane. You have to really hug that bone as you come around the corner. Once that's done, then you see the middle ear mucosa. You can go through that and finish the elevation of the annulus. Dissecting in this corner is also potentially hazardous, and being cautious not to disrupt the incutostapedial junction with a curette or a diamond Burke, and it's also something to be careful about. In stapedectomy, of course, you don't want to suction over an open vestibule. So if there's blood covering an opening in the vestibule, you don't want to suction right over that, but suction to the side. Be careful, even with a 24 suction, not to put your thumb over the opening so that you can remove the blood and see the stapedotomy. How do you avoid pearls? This is just simple. Unfold the curled edge of the flap when you're done with the case so that it doesn't form a little pearl in the canal. If you get a small rent, what do you do? Well, you recognize it and patch it. Always look along the edge of the annulus to make sure there's not a rent. If somebody has a perforation going in, I won't do the stapedectomy. Correct the perforation first, 5 minutes. Okay, we're to tip 9, we're almost there. So one last story I wanted, well, I got 2 last stories I'll quickly tell you. One of them is that you want to inspect the prosthesis before you put it in carefully to make sure that it's not defective. I've only had this really happen once, but it was Dr. Lindstrom and I were talking last night at dinner about the McGee prosthesis. It's a very nice prosthesis. It has a platinum ribbon that goes down to a Teflon core into a piston. And I placed a McGee prosthesis in a patient through a stapedotomy, and I put it on the incus, and as I inspected it under the microscope, I could see that there was a small tear in the platinum where it went down into the titanium, or into the Teflon core. And I thought, I can't leave that. And so as I tried to manipulate it and take it out, it tore completely, and the piston plunged down into the vestibule. Fortunately, this man was a preacher. I think his whole congregation was praying for him. I used the phone a friend rule. I called my friend Bruce Gantz over at Iowa, and I said, Bruce, got a little situation here. What would you do? He said, put in another prosthesis and don't do a thing. So I said, okay, thank you. I put in another prosthesis. We closed up his ear. He had no vertigo. His air bone gap closed perfectly. And the next day I asked one of my other partners, I said, I had this case yesterday, and he said, oh, I know how to take care of that. He says, you just go ahead and take out the foot plate, you draw some venous blood, you carefully suction away the perilymph, you put the venous blood in the vestibule, and then when it coagulates, you pull it out and it'll remove the prosthesis. And I said, oh, I'll think of that next time. I'm glad I didn't do that. It worked out just fine the way we did it. So a scary situation. We did a little study on long-term follow-up on the McGee stapes piston, and about 11% of them over a couple of years became loose from the incus because of the softness of the platinum. And now there's the Lindstrom prosthesis, which incorporates a little titanium, and it's a little more secure, so that doesn't happen so often. So I remind everyone that otosclerosis can be managed other than surgically, and there are a number of things that can be done that may be useful, but bisphosphonates have shown some ability to help. So I think that I will jump ahead. This is a nice report by Gordon Hughes, where early in his career he reported his first 75 stapedectomies and showed the closure of the air bone gap. Up here is where you want to be. Down here is not where you want to be. He had a slowly progressive improvement in his ability, but I think that to be forthright with the patients, we should report our own results, and it's a good thing to track those. And I have to say I admire Gordon's courage for reporting this very honestly about him taking 75 cases to get up to where the experts reported the results on their stapedectomies. Last example, 65-year-old woman who presented with a left internal auditory canal tumor. We followed her along for 4 years, but she had increase in hearing loss and disequilibrium and wanted us to address this. So we talked about radiation, we talked about surgery, and she decided to have a middle fossa excision. The tumor had grown. We did get a history from her, which was a remote history of smoking. She had stopped. She had a past surgical history, which she reported of hemorrhoidectomy, a sebaceous cyst excision, and she'd had some oral surgery. This is what her tumor looked like. It had grown. So we did a middle fossa incision this direction. See the purple W there? And her postoperative course, on day 3, she reported some serosanguinous drainage, which was oversown. That stopped the drainage. She was discharged. Her daughter was a surgical intensive care unit nurse, and we called her Sarge. Actually, she called her Sarge. She was very vigilant. We sent her out to a rehab unit, which we never do, but her daughter insisted, so we sent her to a rehab unit. And on day 10, she came back with wound dehiscence. And this is really what it looked like, a very ugly opening in the incision here. We went back in and swung a temporalis flap down, got a buttonhole here, which caused problems. The wound was reclosed, broad spectrum antibiotics given. She was cultured, put on intravenous IV. Broke down again. We considered free flap reconstruction. When she did this, when we talked to her about this, she just went ballistic. She threatened suicide to both myself and another person, and so we had her involuntarily admitted to the hospital. That really made her mad. Not a good situation. Not a good situation. We returned her to the operating room. We removed the bone flap, thinking it might have had a loss of blood supply to it, and used some Integra artificial dermis, which placed over the spots that were open. Gave her 19 sessions of hyperbaric oxygen. We did not do a free flap. Continued 6 weeks of IV cefepime. This is what she looked like early on after the Integra placement. Still quite deep defects, but they were healing. And over time, the granulation tissue filled up the space. And eventually, the cosmetic outcome was acceptable to the patient and to us. So why do I tell you such a miserable story? Well, remember I started with doing a careful history and physical. There was something she failed to tell us on her history and something we failed to see on her physical examination. And this isn't a great photograph, but you'll see a little line here. She'd had a facelift. And our incision on the other side came right over that, and we devascularized a little trapezoid of tissue there that broke down and caused a tremendous amount of grief. And had we taken a complete history, or had she given us a complete history, or had we been a little more observant when we were examining, a lot of people don't want to tell you they've had a facelift. So if you're going to be operating this area, look carefully to see if they have or have not. So take a thorough history, do a careful physical examination. In summary, learn from others' mistakes, do all these other things, and you'll avoid a lot of complications in many areas of surgery, and particularly in otologic surgery. And I think I will end there. I'll just show you, this fall, my wife and I had a chance to go to South Africa, and there's a place called Devil's Pool, which is on Victoria Falls up in Zambia, actually not South Africa. I used a telephoto to get a picture of these folks sitting on the top of the falls. I thought, you know, experience would teach me that that wouldn't be a good thing to do. This is where we were sitting looking across at them. This is my brother-in-law and sister-in-law, and I looked down from where they were. That's quite a drop. I don't think I'd want to be sitting on the falls on the other side of that, but nonetheless, you learn from others' experience. So This is Mass Eye and Ear on the Charles in the summertime. This is what it looked like out of my front door last winter. We had about 10 feet of snow last year. It was really great. This is a South African sunset off of Table Mountain at Cape Town. So I will end with that. Thank you very much for your attention. If you have questions or comments, I'd be happy to entertain them. Please. So the question is, with the dehiscent facial nerve over the oval window, how often do you see it, and would you abort that case or try to move it? So the first question is, it's very rare. I think in my career over 30 years, I've seen maybe 4 or 5 cases of it. If you recognize it and it's completely flat like the one that I showed you where it's spread out over the oval window, abort. It's better to put a hearing aid on them. There are times when it will be partially dehiscent and hanging over, and then it's a matter of judgment. If you can see part of the foot plate and you have room to do a stapedidomy, you might consider it, but I wouldn't do it as the first case out in training. If you're a new practitioner, I wouldn't do that. I think aborting and using a hearing aid is a safe alternative. Thank you for that good point. Dr. Lindstrom.
Brad, thank you so much for a wonderful and thorough lecture. It brought back a flood of memories, all of them pleasant. There are a few items that obviously, you came from the Nashville tradition. I can hear Dennis Bodrab's voice in my ear proceed from known to unknown, those things. And Ivo Janica was our guest professor many years ago, and his comment to us was head neck.
Why don't you come up here and save time, so I can't repeat all this, so come so that the folks outside can hear.
So these are just some reflections on your wonderful lecture. And Ivo Janica many years ago gave us a talk, and he said most errors in surgery are due to technical mistakes. And I thought that was a very wise point. I think you've highlighted that. Also, one of our now deceased professors, may he rest in peace, Dr. Joseph Arrigo, who many of us in this room knew, he always had a saying, embrace your complications. I think your example of the wrong side, almost labyrinthectomy, that's a perfect example. You spoke to the family, they were informed. When we take our medical malpractice courses, the most common reason that patients litigate is that they feel they were ignored and not informed of the problem, that the surgeon, in fact, did not embrace the mistake. Last thing, Dr. Malcolm Graham used to say, there is no problem in the temporal bone that 1,000 hours in the laboratory will not solve. And the problem is, and I think it's true, with our residents, we don't have 1,000 hours. And I really loved your advice about mentoring, but I think it's really a tough topic. And our residents, of course, always want to do more. But I'd just like to have, if you have any more insights, when do you say, okay, this is it, I've got to do it, and how do you go about that?
Thank you. Very good. Thank you for the kind comments and a very good question. I would say that there are 2 primary factors in terms of how I let a trainee progress, whether a fellow or a resident in a case. And one is, do I feel like they're making appropriate progress at the time? Are they moving forward in a reasonable fashion? I don't expect them to be fast. I don't want them to be fast. I want them to be careful, but I want them to make continual progress. And when I feel like they're doing what we call recreational drilling, where they're not really making any progress, then I think it's time to step in and say, let me show you how we move things forward here. So are they making adequate and safe progress? And the second thing is, and I hate to say this, but it has a little bit to do with my schedule. Do I have time to let them continue to work at their pace, or does my schedule dictate that I have to move things along? So sometimes there will be times when they're doing fine, and given enough time, I could let them continue to work, but I have to step in. And I do really try to emphasize that you can learn an awful lot by watching and by being very carefully observant of what people do who have experience. And I learned a great deal by watching Mike Glasscock operate. I never operate on any of his chronic ears, but I watched an awful lot of them in the year that I was there. And I learned a great deal by being very carefully observant of what he did. And I think that that can be very educational as well. So the third point I already made was just to try to warn in advance of potential complications. Usually I do it in the guise of not saying, no, you be careful, you don't do this. I turn the medical student, I say, now, in this area, we have to be thoughtful about this. And, so I try to act as though I'm not really giving the rest of the hard time who's working, but I do try to make sure that they're forewarned. So, anyway, thank you for that question.
Thank you very much. That was a terrific lecture.
Thank you. Thanks. Yeah.
South Campus will have M&M in about 5 minutes.
So there's M&M here for the South Campus, right? Stick around.
Can't we just count this as M&M? You don't want to just count this as M&M?
No, this is terrific.